Good evening. I would like to talk to you about microscopical lesions of the transport system of organs. By microscopical lesions, I mean small defects, for instance, blockages of capillaries. And it's typical for these lesions that they cannot be directly seen with classical clinical imaging modalities, and they cannot be accessed with interventional tools. In this talk, I'm going to try to create a relation from these lesions to diseases at organ scale. I'm going to try to infer from large-scale measurements, large-scale clinical measurements, directly to parameters of the small-scale lesions. To this end, we'll use methods of parameter inference and uncertainty quantification. But why is this important? In the following, I will show you on the basis of 5 examples that there's a large number, significant number of diseases that are connected to small-scale lesions. And these are diseases of large organs, major diseases which put a big burden on the healthcare system. Take, for instance, the first example, microvascular obstruction of the heart muscle. Microvascular obstruction is a condition that is related to heart attack, follows heart attack. We know that heart attack is a relatively common condition. It occurs at least 800,000 times every year in the US alone. Cardiovascular diseases are the most common cause of death in the industrialized world. But luckily, there's a good treatment for heart attack. If you arrive at a hospital with a heart attack, most likely will present with such a condition that one of your larger coronary arteries, approximately 2 millimeters in diameter, will be blocked by a so-called plaque and probably by a blood clot. The doctor can use a catheter to remove the blood clot, can use a balloon to open up the vessel again, and maybe places such a wireframe stent to keep the structure open. What the doctor sees during this intervention is shown here. This is a fluoroscopy. It's a live X-ray image. They inject contrast agent into the vessels, and you see the vessel structure. Except here at this little stop, here you see it ends here, and that's exactly where the blockage is sitting. And after the placement of the stent, this is what it looks like. You see the vessels open again, and contrast agent and blood, of course, flows into the vessel again. So problem solved. Well, not really. In approximately 40% of all cases, patients are not able to fully recover after heart attack, even though the primary blockage might have been successfully treated. And some of these patients will go into heart failure. So we may ask ourselves, what is happening in these patients? Why do they not respond that well in the long term to the successful treatment of the primary blockage? Well, part of the problem is probably microvascular obstruction. And as the name says, it's an obstruction not of the larger coronary arteries, but of the smallest blood vessels. So on the right here, we see histology of a vessel. I think that's a 200 micrometer vessel. And this red structure here in the middle, this is probably a microthrombus, a small thrombus. Most likely during the removal of the big thrombus in a large artery, the thrombus fell apart into small pieces, was washed down, and blocked downstream vessels again. It can also be that you have cases of swelling or edema, which is blocking these vessels. But what is common to all these blockages is that these blockages cannot be seen in the fluoroscopy. It's just too small. The resolution of this imaging modality is not good enough to resolve these blockages. Neither are the catheters small enough to access these blockages. So apparently there's a scale discrepancy between lesion on a sub-millimeter scale and these tools that the clinicians has. But let me give you another example. Small for size syndrome of the liver. The liver is a large organ. It's heavily perfused with blood. There's roughly 20% of the bloodstream going through the body. 20% of that is going through the liver at any given point in time. There's the possibility of tumors in the liver, so liver cancer. And there's a very good curative treatment for liver cancer. And you can actually cut off parts of the liver resection. Livers have the ability to regenerate or regrow. So if you cut off a part of the liver, it can regrow over weeks and months and go back to its normal function. Of course, there's a limitation to this resection, and the remaining piece of liver should be, let's say, roughly at least 30%. If you go less than that, you run into a problem. The liver stops regenerating, and we talk of the small for size syndrome. Now, again, you may ask the question, why does the liver not regenerate anymore if it's too small? We studied that actually together with visceral surgeons on a pig model, and we did, or the surgeon did a major resection of approximately 70% of the liver, and we studied the flow in the portal vein. This is this blue vein going into the liver. In that case, we had a flow of roughly 1.2 liters per minute through the liver pre-resection. And then we cut it off. And if you think of the liver as a porous medium and you cut off 2/3 of it, you remain with 1/3 of the liver. And you can estimate that the overall resistance of the liver, if you cut off 2/3, will approximately triple. And of course, if you have a constant pressure gradient across the liver, also your flow will decrease. And of course, that's exactly what happened. You have this point here, pre and post resection, portal venous flow dropped to about 0.7 liters per minute. And at the same time, the calculated resistance, the transhepatic resistance, significantly increased. That was normal and expected. What happened after was not expected. Namely, in the hours, talking about 6 to 12 hours, the portal venous flow recovered. It even overshot the baseline value before resection a little bit. Okay. So what is going on here? We still have only 1/3 of the liver here, but after a while, the flow completely recovers. And even though we have only 1/3, we have per liver volume 3 times the flow going through the liver volume. This cannot be good. To understand what's going on, we need to go a bit more into detail in the anatomy of the liver. Livers are composed of these hexagonal structures called hepatic lobules. And in each of these lobules, there's these vascular structures organized in these rays. And one of them is the so-called hepatic sinusoid. This is a small vessel, a capillary vessel of diameter 10 microns. Its wall has holes in it, it's fenestrated, and these holes are there for the exchange of fluids with the surrounding hepatic cells. Typically, in a healthy liver, these windows have a size of around 0.5 microns. After this resection, after the flow recovered, we measured it again, the size of the windows doubled or even tripled. And we see this again here, control picture. You see here these holes, these gaps, these are these fenestrations. And after the partial hepatectomy, the liver resection, the whole structure was obviously damaged. The windows were larger, the structure were torn apart. So what we think that most likely is happening in this situation is that immediately after resection, of course, the resistance goes up, there's less blood flow going through the liver. The body reacts to that and once you put more blood through the liver, opens up the proximal vessels, blood pressure increases upstream of the liver, and more blood is pushed through this small bit of the liver. And this large blood flow will then actually structurally damage the sinusoids. And of course, once they're opened up, once they're torn open, the resistance decreases again, and then the flow can go back to what the body thinks should be right, of course, what is bad for them. So again, we have a situation here where we have a large-scale problem, an organ-scale problem, that we can diagnose with measuring the blood flow through this portal vein, and the cause for it is at the microscopic scale, in the scale of the sinusoids. So based on that, I would like to postulate that there is a scale challenge in clinical medicine. Scale challenge in the sense that the imaging modalities, here fluoroscopy, but the same is true for a CT or for an MR, the resolution of these is just not good enough to see these small scale lesions at the lesion scale. Same is true for surgical tools, for catheters, interventional tools, and so on. So we have the organ scale going from millimeters to, let's say, tens of centimeters. And we have the lesion scale down here, capillaries, a few microns large. Maybe here, this is a crosscut through a lung, and you see these porous structures from the alveoli of the lung. They're somewhat larger, they're a few hundred microns. But still, there's this gap, this scale gap between the two things, between organ scale and lesion scale. And in order to get better diagnosis and treatment, we need to overcome the scale gap. So what can we do? Well, one thing we can do is, of course, to improve our tools, to miniaturize our surgical tools, interventional tools, to improve our imaging modalities. So here I just show you an image I just recently received from a good colleague of mine from neuroradiology. This is a picture of a brain, with a large, I think it's an edema here. And the picture on the left, so it's the same brain, left and right. The picture on the left was done with a 3 Tesla MRI. That's a machine as it's commonly found in many hospitals nowadays. And the picture on the right is done with a modern 7 Tesla MRI scanner. So a bigger machine, more modern machine, and high resolution. So you can see you get very nicely resolved small vessels. And even here in this edema, you can see the cross sections through small blood vessels. So that's cool, and that's of course going the right direction. At the same time, we are still at the voxel size of about 0.4 millimeters here, and we cannot get down to the scales that we would need. So we also need to work on the other end. We need to work on the small scale. And we can, of course, study pore scales of organ. We would like to call them pore scales here. So for instance, on the left, you see visualization of an experiment that we did to study what red blood cells are doing in capillaries. So these are microchannels of width, let's say 9 to 10 microns, so approximately the size of capillaries. And these are actual red blood cells flowing through here. And we are trying to understand if they go left or right, because that determines where the oxygen supply is good. And you see you have complex dynamics, complex mechanics of the red blood cells itself. You have particle-particle interaction, you have fluid-particle interaction. And you can go one level higher, and you can connect a bunch of these bifurcation and vessels and create full networks, capillary networks. And you will find that there are so-called preferential pathways the red blood cells are taking, and there will be certain channels or capillaries which are depleted of red blood cells. And there's still flow in it, but no red blood cells. And you can get yet another level higher. This is also an experiment. I just couldn't find a movie of it. This is again a complex hexagonal network, but we added an active structure to it. Here, this green circle indicates a location where we can actively dilate this local channel. And by dilating this channel, we modify the flow in this whole network. And we measured how this is rearranging the distribution of red blood cells. And where it's red, we have a significant increase by about 20% of the local hematocrit, that's the red blood cell density. And in blue, we have a decrease. So we have a rearrangement of where the red blood cells go or where the oxygen is offered. And this helps us to understand how regulation mechanisms inside the organ may work. So this is important and interesting at the same time. It does not yet create the connection to the organ scale. So to get this, we need to go into multi-scale modeling. Let me come back to the first example, the microvascular obstruction. To study that, we built a benchtop multi-scale model, which comprises here on the left a pulse duplicator that's essentially modeling what the heart is doing. It's a beating heart, creating pulsatile flow, and connected to it is on this table a lot of plastic tubing, and this is a model of the coronary circulation with a lot of resistance and capacitance element in it. And the box here in the middle, this little element here, is a microfluidic chip, which is a small piece, a small model of the microcirculation of the heart muscle. And we see this down here. This is microfluidic chip with a vascular tree here and on the other side. And it allows us to block parts of this vasculature, like to do artificial microvascular obstructions in it. And here in this experiment, we infused a black dye to simulate the infusion of drugs and to see where the drugs are going. And on the top, you have the non-obstructed side, and on the bottom, you have the obstructed side. So this is multi-scale modeling on a benchtop model. Of course, we can do the same also in computational models. Let me show you this for the third example, cystic fibrosis of the lung. Cystic fibrosis is a congenital disease of the lung. It's a chronic disease. It leads to formation of mucus inside the airways, mostly smaller airways, or starts in smaller airways, and impairs the proper ventilation of the lung, might even lead to the complete blockage of parts of the lung. It's desirable to diagnose this condition very, very early in infants, because then the treatment can be very effective. At the same time, in infants, this disease is not yet very developed, and it's very difficult to diagnose it because it only affects really the smallest airways. And the doctor, of course, does not have direct access to the smallest airways, and the imaging modalities cannot resolve. So what doctors do to diagnose that is they use the so-called multiple breath washout. Multiple breath washout uses a device like that. It has a flow sensor in it and a sensor for nitrogen concentration. If you normally breathe, your lung will be filled with air and with nitrogen, 78% of nitrogen. And if you inhale through this device pure oxygen, let me start the animation here. If you start to inhale pure oxygen, so this is shown in blue, blue is like 0% nitrogen, pure oxygen, you will successively wash out all the nitrogen you have in the lung. Right? You can see that with every breath, you exhale some of the nitrogen that is left in the lung. And we see here in this curve, the concentration curve of what is coming out at the mouth. Right? So to speak, what we see at the mouth is like the integral or the convolution of everything that is happening here in these lower airways, or here, these trumpet-like structures. These are like the lowest parts, the acinar structures of the lung, which hold the nitrogen the longest. And you see a certain heterogeneity in this result. Is a wanted heterogeneity because that's how the lung is formed. And you might have recognize that here in this part, there's still a higher random concentration of nitrogen. This is because in this example, we modeled a slightly obstructed airway. I think it's about here, which makes the washout less efficient in that part. And of course, that will have an effect on the washout curve that we do see here. So doctors look at this curve and try to infer from this curve what is happening inside. They're not just looking at the whole washout curve, they're also looking at like single exhalations, like single peaks here. Let me show you this on the next slide. You can actually discriminate different phases in these curves. And phase 3 is what is most relevant for the smallest airways. And doctors actually measure the slope of this phase 3. And we use this forward model to show how the slope of this phase 3 is affected by structural, or let's say mechanical changes in the smallest parts, the smallest airways of the lung. So this is a classical use of a forward model where you do parameter studies and you try to predict what comes out. But this is not yet parameter inference. That's what doctors would like to do. They would like to have the clinical data and ask, so what does this clinical data tell me about the microscopical lesions? How this could be done, I would like to show you on my fourth example, arteriovenous malformations. Arteriovenous malformations are a malformation of the cardiovascular tree. In healthy vascular structures, you have arteries and veins here in blue, and they are connected through a capillary bed. These are small vessels, so you get low flow, high resistance, so you get a big pressure drop from artery to venous side. In a malformation, an AVM, you actually get a shortcut between the two sides. You have much larger vessels here, and they shunt the blood directly from the arterial to the venous side. The shunting has multiple adverse effects. On the one hand, you don't have a pressure drop anymore, or a much smaller pressure drop, so you'll have a much higher pressure on the venous side. That tissue is not made for this large pressure, so you'll get deformations, you might get aneurysms, you'll get tissue swelling on that side. Plus you get a steal, so a lot of the blood, instead of flowing downstream to the periphery, like to your toes, they will just be shunted to the arterial side and go back to the heart. So you'll get ischemic conditions downstream of such AVM. There's a few more things that really make these AVMs dangerous, and they need to be surgically treated, removed. To decide on the correct treatment, doctors need to properly diagnose such AVM. There's classifications of AVMs. There's different angio architectures of how they can be shaped. This here is a classical classification structure, type 1 through type 4. But of course, this is not what the doctor sees when they look at a patient. What the doctor sees is shown on the right-hand side. It's again, these fluoroscopies, so these are movies. Here is the case of a foot of a type 3B AVM. The doctor is injecting contrast agent to the artery. It's flowing downstream into the AVM. Here in this region, this is probably a little aneurysm, and then it's flowing back after some time into the veins. You see that it's somewhat diluted or dispersed because there's a lot of different pathways and dispersion of the signal. And this is our corresponding cases for different AVMs. And you see it's quite difficult to see really significant differences between these images, but a well-trained doctor can actually look at these movies over and over again and then decide on which type this picture comes from. Well, what we tried is to use a modeling to get a bit more of a deterministic way of trying to classify these different types. So what we did is we tried to create a multi-scale model of this vascular tree we used lumped parameter models where the basic element is such a model here, consisting of capacitance, resistance elements, and inertance elements. They're arranged in a way that we have an arterial side starting here at the aorta, going on the unaffected side of the body all the way back to the heart. We have the affected side, part of the body, could be like one arm, one limb, and that has an AVM in it. So this is the pathway through the capillary bed, and this is the shunting from arterial directly to venous side. In this AVM, we can place different shortcuts, different architectures, different shapes of aneurysms. And there's also, sorry, not aneurysms, of malformations. And there's also a type of malformations inside the capillary bed, which is down here. So we model the capillary bed also with a network, with a complex network of vessels. Now, there's a high variability of these networks, and it's difficult, or it's actually impossible to have just one prototypical network. So we actually used statistical data from the literature on the size, diameters, length of these vessels to create many possible realizations of such networks. And we also created many randomly sampled possible designs, architectures of such shunting structures, AVMs. We ended up with a few hundred of these models, and we used these models and ran through a virtual bolus of contrast agent. And the input function, the contrast agent at the input, is this red curve here, was flushed through this network, and we measure will come out on the other end, and you get a delayed and diluted, or not diluted, dispersed output function. And of course, the dispersivity and the amount of delay tells you something about the character of this AVM, the architecture of the AVM. We plotted the delay and the dispersivity of this AVM in this chart, and every symbol here is one realization of such a microvascular network with or without AVM. And we were able to build clusters for different types of AVMs. Here in green is the case, the healthy case. In orange, the case with type 4, gray, type 2, or type 3. So such a map is a tool that can be used by a doctor to place his patient in one of these groups and to decide to which architecture such a patient belongs to. To test that, we also use clinical data. We sampled at the artery and we sampled at the venous side, and you have read the input function, the way the bolus was infused. You see there's quite a variability. And on the other end, on the venous side, we have the output function. It's shaped differently. And you can think of the AVM, the malformation, to be like a transfer operator between input function and output function. And we can try to determine the shape of this transfer operator. And we entered the shape of this transfer operator into the plots here. And these are the circle symbols. And luckily, they match our predictions from the computational model quite well. So let me come to my final example, multiple sclerosis. Multiple sclerosis is a chronic disease of the nervous system. It affects the myelin sheath of the axons. But what it also does, it opens up the blood-brain barrier in the cerebral vasculature. So capillaries, or small vessels in the brain, are becoming leaky. And doctors are using this property to diagnose or to find the location of these multiple sclerosis lesions, or plaque, they call them. So what they do is they infuse a contrast agent through the vascular system, and wherever it's leaky, some contrast agent will leak out and will remain in the extravascular space. And this will shine up as a bright spot in the MRI. So this is more or less what this looks like. You see here on the left an MRI image of a patient with MS. So this white spot here is a classical MS lesion. And if we sample the MR signal over time at this location, we get this red signal curve. And if we sample it for a control on a healthy part of the brain, we get such a signal curve. The question is now, can we use these two signal curves, or can we use such a signal curve to directly infer, only based on this one curve, what the leakiness of that lesion is? How leaky is it? Can we quantify that in numbers? Can we infer a parameter? The problem is, of course, that this leakiness happens in these capillary structures. This is an actual image of the brain cortex of a rat. And you see there's lots and lots of these small, tiny structures which have a diameter of, this is a zoom in here on the right-hand side, of about 5 microns or even less. So again, we need some multi-scale modeling to tackle that problem. And many people have done this with 2 compartment models with limited success. There's a vascular compartment and an extravascular compartment that's on transfer between the 2. We means this was actually Timo Koch who did great work from the group of Bern Flemish and Rainer Helmig in Stuttgart. So what he did is he took a mixed dimension model for flow and transport on a subvoxel scale. This comprises a microvascular tree, where the contrast agent can be transported efficiently, mostly by ejection, and it comprises a 3D matrix into which the microvasculature is embedded, which we treat as a porous medium. So we have this viscous flow inside the vascular network. We have a Darcy type flow in the extravascular space. We have a Starling type exchange of mass through the vascular walls into the extravascular space. We have contrast agent transport inside the vessels, mostly by advection, and we have a contrast agent transport inside the extravascular space by the Darcy flow, and we have a diffusive transport through the vessel wall for the contrast agent. So this dW is the diffusive wall conductivity, and we'll see in the following that this is actually the parameter we're looking for. This is the parameter which determines how leaky the vessel actually is. This model has a lot of parameters, and one of the maybe most obvious things you can do is you can try to do parameter fit. You can try to find a set of parameters that fit one or the other curves quite well, and these are best fits that we achieved here. And if we look for this parameter d omega, we see that in the lesion case, the diffusivity is much larger, about an order of magnitude larger than in the control case. So you could say, well, mission achieved. We know there's a difference. Now, this is not the whole truth, and that's an important point I should make for every biological system. There's a lot of uncertainty in any biological system, given alone, let's say, that the way the contrast agent is infused into the brain is, for instance, described by the parameter A, and there's a lot of variability in that. There's also a lot of variability in the way the MR scanner is working, the permeability of the tissue, and so on. So we should respect this uncertainty in the system, and we should use tools of uncertainty quantification to study this in more detail. So what we did is actually Bayesian parameter inference. We used the Markov chain Monte Carlo method to sample from this large parameter space, and we got these beautiful plots out of it, which I not explain in detail, except that you get estimations of probability, posterior probability distributions, with the prior that you have either this curve here on the left or that curve on the right. And I would like to focus here on these two histograms for this diffusive wall conductivity, which are estimations for the probability distributions of this parameter. If we compare the peaks of these two histograms, we see they're separated, and one peaks at 7. Mind you, it's a logarithmic scale, and this one peaks at around 8, as there's about an order of magnitude difference. So if I plot these histograms side by side, we see here again the peak somewhere at 7, and here the peak at 8. So these are estimations for the probability distributions of the parameter dW based on the prior of these two different curves. So this is a probabilistic information on what what this parameter d omega probably is. And it's a much stronger information, which is much more in the language also for the doctor can use. Doctors are well aware of the uncertainty in their diagnosis. So let me conclude here and say what we actually achieved. We used the multi-scale computational model to do a parameter inference, which allowed us to take directly an MR signal out of the clinic, an MR signal, and use this signal to give information about the probability distribution of this leakage parameter. And we could show that this red curve probably comes out of a distribution centered around 10 to the minus 7 meters per second, whereas the green curve comes out of a distribution that more looks like this grayish white distribution, which is about 1 order of magnitude lower than the lesion case. So what are the take-home messages? There is a scale challenge in clinical medicine. Interventional tools are unable to access these lesions. Diagnostic modalities are not able to resolve these small-scale lesions. We need multi-scale modeling of organs to understand these mechanisms. And at the same time, we need parameter inference methods and certainly quantification to connect these models to produce meaningful data, clinically meaningful data for doctors, and to respect the inherent uncertainty of the biological system. With that, I would like to conclude and thank you for your attention.